And if you go on the our health insurance subreddit, extremely common question now of just hey, should I just not get health insurance at all? These are my premiums. This is kind of what I'm paying. This is kind of the drug I need, or blah, blah, blah. And for a lot of people, that answer is actually probably no.
The healthcare system that we have today in the US is drastically supply constrained. 23 million Americans work in healthcare, yet we've got long wait times. 100 million people plus don't have access to a primary care doc, 40-day plus wait times to see a doc if you can't.
The existing healthcare system, they really want to create standardized care for people, right? And standardized guidelines to make medicine good at the median level for everybody, right? But at the same time, people want more agency in their healthcare in some capacity. No one wants to be told hey, just wait and see.
Nikhil, what's happening?
What's up, man?
So healthcare's off to a hot start in 2026.
JP Morgan always kicks us off in a good place.
The group chats are buzzing.
Of course.
OpenAI dropped some new healthcare news. They got a health app.
Totally.
PHR,
Anthropic too.
Anthropic too. PHRs are back.
Mm-hmm.
President Trump announced the great healthcare plan today.
I haven't read it yet, so please don't ask me any questions.
I was going to quiz you. I was going to quiz you on that. Utah is letting AI prescribe medications.
Of course.
That's happening. FDA rolling back regulations on wearables.
Wearables. We're doing Bayesian trials now.
We're doing it all.
Crazy.
And we have a new food pyramid.
We do.
So a lot to talk
More
about.
like a downward arrow now.
Yeah. It's inverse pyramid. I ran your 2025 predictions through Claude.
Of course.
You got a 7.623 out of 10.
Already for the year? It's only been 2 weeks.
No, last year.
Okay.
I put last year's predictions. So
hey, that's pretty good.
It's really good, actually. It's
Yeah.
it's too specific to mean anything.
Totally.
But it's good.
Nice.
So it sounded good. But I thought you went spicier this year. I thought your 2026 were spicier. So we're here to debate them.
Okay, let's fight.
Let's fight right now, and then we can check the Kalshi prediction markets
Sure,
afterwards to see who won.
We got to put money where this is.
Yeah,
now.
yeah.
It's not a predictions post anymore unless you have some Kalshi, some money in a prediction market.
If you don't have dollars at stake,
What's
what are you
the
even
point?
doing? Why are you even doing it?
Exactly.
Yeah, exactly. All right, so let's start with your prediction on health insurance defection. I've got them all up here.
Cool. Yeah.
I think that sets the stage on where we think healthcare dollars will flow in 26, and then will flow into the others. So one of your predictions says that uninsured rates explode.
Sure.
The uninsured rate explodes, and the second order effects. So people refuse to play the healthcare insurance game, defecting from the system.
Sure.
The rate of uninsured people will skyrocket to 15%, leading to consequences like flooded emergency rooms, spiking insurance premiums, and more cash pay options.
Exactly.
So today, the uninsured rate is around 9.5%. I had to look that up. As low as 3% in Massachusetts, 18% in Texas.
Oh, wow, I learned something.
Yeah. In 2009, 2010, pre-Affordable Care Act, it was around 15%, which is 16%, which is where you projected it. So 15 years of progress unwinded in 12 months, if you define that as progress.
Sure.
And the whole country is about to look like Texas. So lay that one out for us. What made you think that?
Well, I mean, it's a combination of things, right? At the time when I wrote this, obviously, premium subsidies were still a big debate. So it was unclear where that would sort of shape up. And, where I live in New York, for example, we have a extremely high cost insurance individual exchange market, right? And this for a whole host of reasons that we don't have to get into. But it seemed like the premiums were going to spike across the board for the individual exchange.
Right.
On top of that, small group insurance is kind of going through this weird thing right now where one, if you have relatively less sick people, you're like, hey, why am I subsidizing the pool of the more sick people? Let me exit it through, things like level funding or any of these other things, or even just not offering insurance at all, right? That's now an option because the labor market has so far tilted to employers that if you're below 50 people, you don't have to offer insurance either, right? So I think a lot of employers with healthier employees will be like, hey, I don't want to subsidize these sicker people. And then the employers with more sick employees then are left in their own pool. Those premiums skyrocket. And then the employers in that pool also have the option to not. So basically, I think there's a lot of reasons why people will eventually just say like, hey, should I really be paying, I don't remember what the average premium is, but like, $12,000+ a year for a family with a deductible on top if I don't even use health insurance at all, right? People are getting squeezed, obviously, and, their individual wallet share and all that kind of stuff. So they're going to be asking themselves, and if you go on the like our health insurance subreddit, extremely common question now of just like, hey, should I just like not get health insurance at all, right? These are my premiums. This is kind of what I'm paying. This is kind of the drug I need, or blah, blah, blah. And for a lot of people, that answer is actually probably no. Like if you think about it for a second, like if I were to like be really rational about this and I'm thinking, okay, I'm a relatively healthy person with no expected procedures or medical things this year, like nothing planned. If I believe that, then, and my premiums, let's say on the individual market are $550 a month, which is in New York, plus on top of that, probably like a $5K, $6K deductible, right? Now suddenly, like you just do the math, right? It's 12 times 600 plus the $5K deductible. So before even anything is covered at that point, right? You are paying like 10, 15 grand depending on who you are. And I'm really just protecting against like catastrophes, cancer, car crash, whatever. Then it's like expected probability of that thing happening is like relatively low. And so I can totally see for a lot of people saying like, it's just not worth it for me.
Yeah. So let's talk about the likelihood that it's going to happen, but like almost just rewind the clock a little bit.
Sure.
Is this a good thing? Lay out the arguments for both sides.
I mean, the con is sort of obvious, which is that I think a lot of people who are not good at guessing their own risk will have something happen to them and then end up in a hospital and have to pay a ton of money that they just don't have, right? So that's one con, is that coverage for people goes down and something bad happens to them and then they have to deal with it, right? So that part's bad. And also, I think that depending on what your view is on should we have health insurance at all, then if you believe that we should have health insurance in like a health insurance industry as in general, then this totally fractures like the risk pool, makes our economics all wonky, blah, 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 and will probably just lead to like a handful of payers that do the whole country. Like 4 or 5, right? You're already seeing this right now. Smaller health insurance companies getting bought by larger ones, like happening at rapid scale. A lot of the Blues plans are consolidating, all this kind of stuff. So if you believe we should have a competitive health insurance ecosystem, this kind of defeats that purpose a little bit. The pros of it are if you believe more in a consumer-directed healthcare system in some capacity, where, hey, people get money and they should just use that money to pay for services they think are worthwhile to them, then this is sort of the like means to do that, right? Like if people feel more healthcare costs directly, they will be better shoppers. People will try to cater to them more, so there's a better experience and all that kind of stuff. So, I mean, I think a lot of people probably, rightfully make the argument that like having a third-party payer is one of the reasons that costs are so inflated. It's one of the reasons the experience is so bad when you're not the direct customer, right? So those are the pros and cons of it. It really just depends. There's no right and wrong. It just depends on what your ideology and what coverage should look like is. To your earlier point about Affordable Care Act before and after, right? Like one of the beliefs was we should have a competitive health insurance market on the marketplace. And they will, if everyone is on the same marketplace, then they'll compete for people and it'll function like a normal marketplace for a whole host of reasons that didn't happen. So now the question is, should we go back or should we try and double down and fix it? And not clear.
I think there's, if I were to steelman the libertarian case, which is sort of what you talked about around the free market, let the consumers kind of choose. It's basically saying, some people will say, finally the market is working. People are defecting because the product is bad. Let them defect. The product will get better. If they want those customers, they'll get them back, or they won't. And people are voting with their wallets. So that's one side. The other side is basically the free rider counter argument. We kind of heard this back in 2009, 2010, ahead of the Affordable Care Act, was people would go and say, I'm going to go without health insurance, knowing that there's a federal law that effectively requires hospitals to take care of them.
Yep.
And the belief or the worry was that people would would sort of stay away from the traditional care, preventative care, and just wait until things get really bad, and then they end up in the hospital and then it's paid for. ER is the most expensive site of service. It's the least affordable way we can deliver all kinds of healthcare. This increases costs for everyone. Hospitals have to pay for it, and the uninsured effectively result in all this uncompensated care that we inadvertently pay for anyways, in higher prices. And so overall, it makes the system work.
Sure.
You think we're going to have the free rider problem again with this, or does this time feel different?
I mean, we'll probably still have that problem, right? Like if people don't have insurance and they get sick, it's not like they're going to like stay home and just ride it out. They're going to go to the emergency department, obviously.
Right.
So we're definitely going to have that. I do think that, there's like I think the main ideological question is like, how do you think we as a country should treat catastrophes in healthcare? Right?
Yeah.
Like, I think a lot of the stuff that people talk about when they're like, hey, people vote for their feet or want to go is shoppable, plannable things, right? And that totally makes sense. But what do you do with a person who gets in a car crash, right? Like, people always make the argument of like healthcare can't be shoppable because people aren't going to shop for an ED. They're not going to be on the emergency department shopping for things. And it's like, but that's like a really specific case.
The highest acuity,
exactly,
really bad, expensive stuff.
Yeah, and so if you look at other countries' models, for example, right, like Singapore, maybe is like the most common example here.
Yeah,
they try to separate those, right? Like they try to make shoppable services more of a cash pay experience with their their version of what looks like an HSA, and then the government covers more catastrophic things, right? Cancers and inpatient and all this kind of stuff, right? So maybe actually this is us speed running to a system like that, where you're like, okay, hey, we got a bunch of cash pay patients. They're also about to show up to these higher acuity places, and we need to figure out a way to cover them, and we need a scheme to do that, right, in some capacity. So
you could also argue that the goalpost has moved in the culture around health. There's clearly a greater cultural movement around health right now. We've got MAHA. Consumers are spending more out of pocket for health. Alcohol sales are down. Supplement sales are up. And so
we're not drinking alcohol. We are injecting peptides.
Yeah, exactly. We'll get to peptides. We'll get to peptides. One question that I think a lot about in comparing this to the kind of free rider problem that people talked about a lot in 2009 and 2010 is, are these actually different populations? There's one population, which is the proactive health crowd, higher income, they're buying supplements, they're on, they're buying GLP-1s out of pocket, they've got an Oura Ring, a Function Health membership, a council membership, they're doing all the things.
All your friends.
Exactly. They're working with everyone. They were already insured and they're likely going to stay insured, but then they're doing these extra things out of pocket. And then there's the newly uninsured that you're arguing is sort of accelerating. People are losing coverage because subsidies expired, because the big beautiful bill had Medicaid cuts, and now they can't afford it anymore. And we're not doing a good job as a country taking care of those people. What do you think of that distinction?
I mean, I think at the end of the day, everyone wants to be healthy, right? Just the way they define that is a little different, right? Like I think there's a group of people, probably again on the higher income scale, who are like, I don't feel like I'm being taken care of because there's like, I'm not being monitored, for example, right? Like the healthcare system is sort of not designed for my view of how I think healthcare should be. And so I am opting out into a separate system that I think more aligns with my view, that is more consumption, I want to be able to consume more healthcare, and this is like the way to do it. More lab tests, more MRIs, whatever.
Right.
I think if you are lower income, you still obviously want to be healthy. No one like that is still the goal. But I think the problem set is a little bit different, right? Which is like, I don't want to have to take off work to do a doctor's visit for just a prescription refill, for example. Or my kid is sick and I just need the answer to like what is happening here, right? Or the drug I normally take costs X amount now. How do I get it for cheaper, right? I don't think that's like, I mean, maybe the problem set is a little different, but the end goal is still the same. It's just like the way people think about healthcare, about like what is good health, is just going to be, different between those groups. But they still want, like, everyone wants the same thing. They want healthcare. They want healthcare for cheaper, or like, actually, one thing is that I think is very common is everyone wants more transparency on the pricing, right? There's like, hey, I think I need to go to the hospital, but I can't do like $100,000 bill, right? Like, or I want to get lab tests done, but like no one is telling me how much it costs if I like go to the hospital to do that, right? So everyone wants price transparency, and like I think the cash pay market on both ends like try to serve that.
You think there's going to be a third category that emerges here between those two camps? As an example, a member of the middle class who could afford insurance but chooses to go uninsured. They probably would have got health. They either work for a very small employer that maybe doesn't offer healthcare, or they, work for themselves and they would have bought on the exchange, as an example, and they're going to bet on cash pay plus proactive health and risk it. Because that would be a third category in between these two. Do you think that's where the growth in uninsured comes from?
So do you know what health sharing ministries are?
Yeah.
So this is like
explain this. This is interesting.
Okay. So for people who don't know what this is, it's basically instead of health insurance as you know it, which is like, hey, I pay premiums and into this pool, and then when things happen, they pay out to other people. In health sharing ministries, the high level is you preload a wallet essentially with something that looks like premiums, but it's technically not premiums. And then when other members have a hospital bill that happens, people contribute from that wallet to pay for the hospital bills. So it's a little bit more of like almost like crowdfunding for healthcare, but amongst like a specific pool of people that are essentially like pre-vetted before they come. So, those are typically much cheaper, and this for a bunch of reasons, right? One, they can do things that plans used to be able to do pre-Affordable Care Act, like deny people based on pre-existing conditions, right? So their risk pool is much better, right, as a whole. And also, they don't have the same regulatory requirements of like, hey, you have to have a bunch of capital on your book so you don't go insolvent when this happens, right? So your regulatory requirements are lower, so your cost for compliance and all that is lower too. But it's like an interesting model where you're like, hey, if I go to the hospital and get a bill and I show this to the people, and then they all contribute to it. But the downside is you better hope that people are actually down and will pay for it. And I do think it's an interesting product for people who are, but I say interesting, I don't mean like I ideologically agree with it, but I do just think
you're not recommending.
I'm not recommending it, but I do think it probably addresses this middle ground a little bit where it's like, hey, like the health insurance I currently have sucks, and it's not covering the things I wanted to cover anyway, and it's really expensive. If I'm already gambling on whether or not the insurance is going to cover me or not, which is the case for a lot of people. They're like, I'm buying this, and then I go and they deny my claim. There's a chance of that happening. I might as well try this other thing, and if I can get in because I'm a healthier person, I pay less for it. So I think there's a lot of people that also just ideologically agree with that premise. So that I think becomes sort of potential for people in that middle zone. But the infrastructure is not built for that because a lot of those people, again, have to go and shop for their own care, negotiate the bill, all this kind of stuff, and some of these health sharing ministries offer services to help you negotiate and all this kind of stuff. But it's just also a very different model of healthcare consumption. Like there's also some cultural change that happens here where people have to go and are willing to like negotiate prices with providers. Like that is not a normalized thing. And maybe that becomes more normal. Honestly.
That makes sense. It's interesting.
Would you sign up for a health sharing ministry?
I don't know. I don't know if I would. And actually, so I don't want our healthcare system to splinter into two groups. One group that can afford to defect from health insurance, go cash pay, and run their own healthcare stack that way. And then folks that are effectively cycling through our existing healthcare system, relying on charity care effectively out of pocket for the health system to pay for it. I spent a little bit of time this year studying different healthcare markets. Mexico, as an example, has that to some extent. It's not a perfect parallel, where there's one system for the rich and another system for the poor.
Yeah.
So that would be the downside case that I would worry about here.
Sure. There is also, I mean, so for one, I think the core problem with U.S. healthcare is just like we have too many risk pools, right? You kind of have to choose one or the other. Like having this like, hey, maybe we're a little cash pay, maybe we're a little bit a little bit insurance. Some people are in employer insurance. Oh, some people are Medicare. Like that's kind of the core problem, right? We have to move to one or the other, right? So, for the ACA, the idea was we'll move everyone theoretically to this individual exchange and everyone will buy from that. That's like, but at least they're all in the risk pool, right? And that looks more like Germany.
Yeah.
You could also do totally cash pay, right? Where it's like everyone is cash pay and you're just focused on that. That looks maybe more like in India, for example, or like a Singapore if you're doing it through splitting outpatient and inpatient out, right? But you have to pick one or the other. Like this, like in between.
Americans love choice. We love choice. Everyone wants to have an option. We pay for the choice.
This is choice in like the worst way, man.
I know.
It's choosing between the worst options now.
Yeah.
But also on the flip side, there's again like the ideological question of, do you believe that you should be able to pay for better care?
Yeah.
Right. And I think that question makes a lot of people really uncomfortable because it's like they cannot reconcile internally that like, oh, people should be able to pay for better doctors. Well, if you don't want that, and that's fine, what ends up happening is that if everyone gets access to one care system, then there will emerge a parallel system that allows them to do that no matter what, right? Because they'll say, hey, I'll pay for the best doctors, cash, even if there is an existing one, and those doctors will exit, right? And that's kind of what's happening today with like concierge medicine and all this kind of stuff, right? Everyone's like, hey, we want primary care physicians to be able to see everyone. It's like the great equalizer, all this kind of stuff. And then suddenly people are like, I will pay a lot of money for you to just like not do that and then come just take care of me, right?
Yeah.
So the reality is that's kind of already happening. I can't think of a single system, even in socialized medicine countries like the UK, people still get private insurance and 100%. to see docs with lower wait times, all this kind of stuff. Like, I don't think it's possible to actually have a system where you can't pay for better care. It just happens. It'll just emerge as an economy no matter what, unless you ban it, right?
Yeah.
Which like you can do, but that has its own sort of downsides to it too. Like Canada, for example, is an example of not being able to do a parallel system, and that has its own issues. Where people are like, hey, if I have a complex care thing, I'm going to come to the U.S. So I don't know. Like, we got to get comfortable with the idea that I think you will probably, no matter what, end up with a system where people pay for better care. Mm-hmm. You can either do that in a really convoluted way, or just do that in a straightforward way, or do that in a way where you're more comfortable with what they choose to pay for, right? So, for example, in countries like India and stuff, you can pay for better amenities, right? Like the nicer wards and all this kind of stuff. Like, maybe that's a more palatable way to do that, basically.
Yeah, it's interesting. So if this plays out, and TBD if it's 15% or 18% or 12%, but it's clear that, per the Reddit threads, which is truth.
That's my truth.
People are defecting.
Yeah.
What are the ripple effects for startups? If you're trying to start something, obviously the proactive health startups have an opportunity here, more cash pay spend, but what else?
Yeah, I think also just like care navigation looks very different for this group of people.
Totally.
Right? I think you have to really think about, is this thing I'm doing serious enough that I need to go see a higher cost medical practitioner if you're paying out of pocket, right? That triaging step is really different. So I do think that helping people figure out like, hey, where do I go for this? And is this actually serious enough that I need to go, becomes a whole separate type of product to build, basically, compared to someone like, if you have insurance, you're really navigating them through their insurance directory, coverage, whatever it is. So I think that looks very different. I think another ripple effect too is there's going to be, I think, a lot of people that try to deliver care at like hyper lower costs, right? So the Doctronic, pilot in Utah is a good example where if I remember correctly, they are doing prescription refills at $4 a pop
instead of $150.
Yes. Yeah. Which, like, that is actually that is relatively affordable. Like if you need a prescription refill, that is like one route you can go rather than having to do a totally net new visit to the doctor, right?
Yeah.
So I do think you'll see more of this, like, hey, how do we bring costs like an extremely low level? Obviously using AI, using tech, using all this kind of stuff. And then the other one, which like I think is a little interesting to think about is, can you do some form of novel contracting with the existing providers for when they see people who are coming in as cash pay?
Yeah.
Right? Because the reality is the providers are going to be in a tough spot, right? Where someone comes in, they have to pay cash. They don't. Like, if they come into the emergency room, they do some really expensive stuff. People leave. They chase them down for the money, and then they don't get it, right? So the provider is in a tough spot when that happens. Can you offer really easy, like bundled payments or whatever it is to people to be like, hey, if you're a cash pay person, here's what our rate is, this, and come through and get it. Right now, like if you wanted to figure out the cash pay rate for something, you like have to go through like a really weird, convoluted process to do this. You call in, you'll say you're a self-pay patient, and you're kind of like haggling. I feel like I'm like in an Indian market.
Yeah,
you know what I mean? I'm just like,
Yeah.
we're haggling back and forth, and we're just like, what's up? What are we gonna beat? But to maybe just make it really easy for everyone, it's like, hey, here's the bundle, here are the services included, like, you can come for this. And that's gonna especially be true for things like somewhat higher cost procedures and stuff like that, where it's like, if you're uninsured and you do really need that thing, here's how we can do it, and here's the cost we'll pay.
It looks more like the medical tourism market where people are coming.
Exactly. It's more local.
But it's a local version of that. But people are coming to the U.S. and they want to get the procedure at Mayo Clinic.
Yes.
They're paying out of pocket. They're not in our system.
Yeah.
There could be a domestic option like that. It exists today, but it just make it easier, lower friction.
It's very hard to do that today. So maybe that's one.
Okay, so we're going to jump around across some of the predictions just to hit ones that are more relevant. If consumers are defecting, coordinating more of their care, and spending more out of pocket, one prediction is that screening, diagnostics, and at-home sample collection becomes the hot area. So lay out the case there. So Lil Jon is doing colon cancer screening commercials. People are shipping their poop around the country like just crazy.
Not even for healthcare.
Not even relevant. They're just doing it. Wash your hands after you check the mail. Lay out that. Why do you think that's going to happen?
Well, to be clear, I don't think it's because the uninsured thing happened.
Sure.
I think that diagnostics is, I feel like such an interesting area that is like very underinvested in.
Yeah.
I think maybe one thing to tie to the uninsured, maybe not uninsured, but cash pay rather, is that I think this is one of the areas that a lot of people, when you talk to doctors and you talk to patients, this is one thing that I feel like there is a somewhat irreconcilable difference here that they just can't think about. Like the people want to be monitored in some capacity. And a lot of the doctors will be like, well, you can be monitored, but there's not much we can do even if you get monitored, right? Like, it's not like your care pathway is going to change doing that. But a lot of people just like want to be monitored, right? Because they feel like someone is looking out for them and they're being considered at all points and blah, blah, blah. So I think that people want that, and especially in the cash pay. And you see this with like the longevity medicine and all this kind of stuff. Like a big component of what they want is just like being monitored, right? Even if it says nothing, it's just at least we checked, So I do think that the appetite for that is really high. I think as you move to more of these AI native care models, that becomes a really core part, right? The shift from reactive care to proactive care really has to come from like, what is the data source that's going to tell you that something has to be done, right? And I think that is going to come from some form of screening, diagnostics, et cetera. We talked a little bit about the AI, about like the AI prescribing, for example. I think the next level above that, which will be interesting, is like AI ordering things like labs or, follow-ups that you might need pre the doctor actually needing to look at it, right? And I think that is going to be sort of a part of this. But in general, like I think diagnostics also are seeing a more interesting go-to-market strategy too, which is, hey, we basically see a big cash pay market that was just wanting to be monitored. while in the meantime, maybe we go through a more legit lab developed test or FDA approval route. But there's this appetite here for these like new tests to just be monitored on different metrics that maybe are not typically monitored. And they see this appetite from people to do that. Like, especially, for example, if you have, some family risk of something, right? But you don't quite fit really neatly into guidelines around like that you need to be prescribed this thing. People are going to find alternative routes to doing that, and they have money to do that too.
Yeah.
They're going to pay for it. Yeah. Coronary, calcium CT scans, like great example of this, where like for some reason it's really hard to get that, and also there's still a huge lag between like evidence and research and then care guidelines, right? So the lag is like 10 plus years in a lot of cases between like what's interesting and what actually makes it into like, hey, we're doing this for all patients and all this kind of stuff. But people are willing to pay to escape that.
Have you done it?
The calcium scan? I'm not, dude. But I'm like, if you're a 30-year-old brown person, like you're suddenly in a risk category that you have to be thinking about this.
I'm a perfect example of what you just described, which is slightly high on the border cholesterol, South Asian male, so I have risk factors.
Canon event.
Yeah, exactly. and so my doctor was like, you definitely don't need a calcium CT scan.
Yeah.
But
what does he know?
But what do doctors know? Just kidding. But I did it anyways.
Cool. What did you find out?
It was a 0, which is good.
Okay.
But I wanted to know that.
Yeah.
It's good to know.
Exactly. Like I think the tough thing, the thing that we have to like figure out as a society a little bit is that the existing healthcare system really wants to be like, hey, they really want to create standardized care for people, right? And standardized guidelines to make medicine also like good at the median level for everybody, right? But at the same time, people want more agency in their healthcare in some capacity, right? Like they want to feel, no one wants to be told like, hey, just wait and see. They just like don't want to be told that. And there are probably a lot more lower risk things that we can just let people try and do and see. Like I think this is one of the reasons, for example, that like protocols are so popular right now, like Huberman protocols and periodic T protocols. The core thing of what these protocols are saying is like eat well, sleep well, the normal advice you get, but
it's branded.
Well, it's branded, but also it gives people like what seems like a task list that they should actively be doing to like be good at their health, and gives them like supplements to feel like they're doing something. Yeah. And whether or not they're doing it is sort of irrelevant, but the feeling of having agency in those situations, I think, is actually the important part. So it's the same with the testing. People just want to like feel like they're in control a little bit. And, I think there's some tension here about like, okay, there's clearly a line of like where patients are just like YOLOing into like screening tests and diagnostics that then end up with like more pressure on the healthcare system. Like you find incidentalomas in your MRI, now someone else got to deal with it, all this kind of stuff. But I think people want more agency, and getting a test done where you're like, I just don't feel good about what my care plan is today. I just like to see and test is just like, for better or worse, just like going to be a part of healthcare going forward.
I think that's right, and I think that creates another debate, which is what do regulators allow these tests and AI applications to say?
Yeah.
So I think a lot of these things, the medical establishment will say, well, it's not really going to tell you anything that actionable or that interesting. Yeah. But these things start on the fringe. My take is that I think it's a good thing. They start on the fringe, and then they get more mainstream. I think the reality is that the healthcare system that we have today in the U.S. is drastically supply constrained.
Sure. Yeah.
So 23 million Americans work in healthcare. Yeah. Yet we've got long wait times. You've heard all the statistics. 100 million people plus don't have access to a primary care doc. 40-day plus wait times to see a doc if you can, et cetera, et cetera. And so all that friction is frustrating, and the demand exhaust shoots off somewhere, and it's shooting off to all these places. Yeah. And to your point, people want agency, so that agency is going to go somewhere. And, where is it shooting off? It shoots off at LLMs. Mm-hmm. So, you saw the OpenAI report, 230 million people around the world using ChatGPT for health-related questions each week. 40 million a day. It's crazy, right? It's crazy. It's like replaced
Yeah.
Dr. Google and many other things.
Yeah.
The proactive health tools are being adopted by a bunch of people.
Yeah.
The health memberships, the wearables like
Yeah.
Aura and Whoop, name your thing. And, that makes sense, right? People want to do stuff with that, but there's still regulatory friction that I find interesting, and I'm kind of curious to see how it plays out this year, which is, at least as of a few weeks ago and prior to that, there were 2 buckets for a device. FDA either said it's a wellness product and it can't make any medical claims at all, or it's a medical device and you can make all the claims you want, but you've got to go through a long regulatory approval process.
Yep.
That, as we know, largely favors the incumbents,
Of course.
the big med tech companies, really hard for startups. So there's not that many on a relative basis devices that have emerged relative to, I think, what could have been possible.
Yeah.
I'm touching my Aura ring as an example. So Tom at Aura, we're not investors there, but I think he wrote this amazing op-ed in the Wall Street Journal that basically said there should be a third category. And that third category is digital health screeners, which is, there's something in between that's not necessarily going to give you direct medical diagnosis, but will show you a couple things that you probably want to know about your body and you might want to talk to your doctor about. So, the examples that he gave in the article that I thought were good were, maybe there's a couple early indicators of high blood pressure that it can infer and tell you to say, hey, you might want to talk to your doc about hypertension. And I think, I can't remember the last statistic, but 40% plus of adults are diagnosed with hypertension or something crazy like that. So it's a real chronic condition, that's challenging. The other one that they give in the article is, hey, there's some sleep irregularities that are probably predictive of sleep apnea. Talk to your doctor.
Yeah, totally.
Right? Like, we should just let that go. And I think there's obviously something in the middle where you could get all this data and then just drop it into your LLM. People are doing it anyways. I drop all my medical data into Counsel and, pick your one.
Yeah.
And, that's where it's going. FDA said some things that suggested that they
give the hint, wink, wink.
Wearables. They're gonna roll back some of these things on wearables, but like, wearables just the start. Right now, you get into AI doctor applications and what can they say, what can they do. So, what do you think of that?
I mean, again, I think the question is, how much, as a society, how much risk do you think that patients should be allowed to take on themselves?
Yeah.
Right. Like, the AI prescribing thing maybe is a good example here, right? And we'll come back to the diagnostics for a sec, but like, do you think that a person should be able to say, hey, I want to be able to pay $4 to see the AI doctor who's going to like auto prescribe me these common meds? It might get it wrong sometimes, and if it does, then it'll harm me. Or I can choose to pay a higher amount and see a doctor that maybe has more sort of like higher accuracy or whatever it is, and lower chance of me doing risk of having an adverse event or whatever, like getting prescribed the wrong thing, whoever. Should I be allowed as a person to make that choice? That like, I want the AI doc that maybe gets it wrong more often but is cheaper, or not? Probably same thing for screening diagnostic wearables, right? Where it's like, hey, here's a thing that might find some interesting stuff in your data, but also it's going to have a false positive rate of this much, right? And you can choose that. Now, I will say the issue here a little bit is that the burden of the false positive rate then falls on the doctor you go and see, or the health system, or the emergency room. So I think that is like a real consideration we have to think about, is like, when people have these devices at scale, suddenly the risk of when false positive rates happen, like, it's going to be millions of people, right? That's like no joke, right? But also at the same time, I think we're missing a lot of really interesting data that we should be doing more things with. For example, I think, been talking to a bunch of people that have been wearing CGMs for a while, and a lot of them, I think, for example, have different pathologies of what like traditionally looks like diabetes. Like, for example, I think diabetes is this like broad category, but there's probably multiple underlying things that are actually happening that are actually different forms of diabetes, for example. Probably the same thing with like sleep, insomnia, all this kind of stuff. There's probably underlying multiple pathologies, but it's hard to tell that unless you have like a more massive stream of data that is coming that can help you tell like how that's changing. and how that's changing from a healthy baseline, which I think is really important, right? I am wearing the Oura Ring today as a healthy person. As I develop a disease, it's going to catch things that change from my healthy baseline to like being a sicker person. And those changes and how that naturally progresses, like natural history study basically, is really important. And I think we probably can do that for more diseases if we had more people wearing this kind of stuff. So
this is the real world data dream.
It is,
really. This is what we all wanted.
Yeah, and I think the problem is real world data has always been focused a little bit more on like pharma use cases. I think there are a lot of people that are also just like, I kind of want to know if there's other people like me who have like this sort of weird sleep pattern.
Yes.
And like, what is that? What are they doing? What does that mean? You know, that's like, I think, a really open, unexplored space that people have not quite, I think if anyone is listening to this, I think building a patient-first biobank on these concepts, I think, is really interesting. People really do want to know how people that look like them or have biomarkers that look like them deal with that or like operate in the world. What does their care journey look like, even if you de-identify it or all this kind of stuff? It's useful to know, like, hey, this person who had this weird sleep pattern took this magnesium dosage and it actually seemed to work for them. And they actually, when we sub-cohort the populations, they look very similar to you. So maybe you should try it, right?
Yeah.
That's very unexplored. And I think wearables and all this kind of stuff is a way to do that. But we can only do that if there is some, way to capture that data in like a like structured way, basically, right? And you need a middle path to do that.
So that's a good transition to talk about. You had 3 or so predictions around healthcare AI, and your first one was around, state governments clashing with the federal government on key regulations. You talked about it across a few dimensions, but let's zoom in on AI. So state governments will clash with the federal government on public health guidelines, vaccine recommendations, AI regulation, insurance law nuances.
All the above.
Let's talk about that. So on AI specifically, I think this is interesting. Last year, we had Illinois and Nevada and a couple other states either ban or restrict AI therapy chatbot usage. Basically last week, so since you wrote your piece, we literally had Utah doing the pilot around AI being allowed to prescribe medications. It's very narrow on 190 low-risk medications, your asthma inhaler, things like that, low-risk stuff to start, but can expand. And then President Trump signed an executive order in December saying that effectively said, hey, we're going to do a national framework and we'll make it easy for folks to follow. It sounds like you think it's going to be more chaotic in 2026. Definitely. Say more.
I think there's a couple things, right? Like, one part is there is definitely an anti-AI sort of movement that is happening in the U.S., which is sort of expected and natural, and people are worried about job loss, and they're worried about how decisions are being made that affect their lives because, like, maybe there's an AI on the other end that is choosing things that are, anti helping them, right? So I understand, like, where that's coming from, and that anti-AI movement will inevitably impact policy. And depending on which state you're in, you are going to have a regulator in that state side with one side or the other, right? Maybe like a analog here is actually like Waymos, right? Like, Waymos are in a few states. They started in California. They are super, like, I love riding in a Waymo every time I come here.
Yeah.
States have very different opinions on whether they should allow Waymos into their own state, right? Whether it's they care about how much they have to prove safety-wise before they roll out, or they know there's going to be widespread job loss when they come in. And I think AI for other things is going to follow the same trend, right? And so I think the issue is that, like, states don't quite know what to do. I think we can all acknowledge that there's a lot of, like, also bad AI use cases that we need to, like, watch out for, right? Using deep fakes in weird ways and a lot of this kind of stuff, right? So as a whole, I think people are trying to figure out, how do we regulate the downside risk of AI while also enabling the, like, upside potential that we can see, right? And maybe it's actually not a bad thing that we're running a bunch of state-by-state experiments to see, like, what works and what doesn't, and then create a more national framework to do this. The downside, though, is then you have to, healthcare's always been really annoying about having you have to, different compliance rules for every state, which means your product looks very different and the cost to go in a new state is very different. That's going to be annoying, but actually maybe we should be running different experiments here. And each state is going to, it's going to look different depending on their own healthcare needs as a state, right? If you have a really large rural population, for example, that really struggles to get access to care, you are probably going to lean more heavily into hey, we need to get these people don't have a PCP.
Yes.
We need to get them something, right? If you have a very competitive provider network, maybe that's actually not the case, and care accessibility is fine and all that. So I think that states are trying to figure out how do we protect the downsides while getting the upsides, but they just don't. They all have a different opinion on what that means. Some states, for example, they really don't want insurance companies to use AI to deny claims, right? They're they think that's really bad, blah blah blah. And
they'd rather have humans deny claims.
Yeah. Which also at the same time, I'm almost how are they even going to monitor that? If a human is using ChatGPT to read the claim and then deny it, is it really any different?
Yeah, sure.
Not too clear, but I don't know. We'll see. Be some fun state experiments.
Yeah, I think that's right. I think from a competitiveness standpoint and from getting all the innovative ideas out there, which ultimately benefits the consumer, I think you've got to have a national framework.
Sure.
Because if you have a lot of regulatory complexity with different rules in every state, it favors the incumbents who have the armies of legal teams that can interpret all those things and operationalize and scale in that way. So you want to level the playing field for big tech and little tech. Mm-hmm. On the other hand, you want the experimentation. I think when the technology is moving so fast, you want regulation to catch up, but you really don't know what the right answer is, and so it's instructive to have different states experiment for their unique population mix and rural to urban mix, as you described. Yeah. And so I think the question for me is, do we have the right data infrastructure to learn from all that stuff? So
Sure, that's true.
The prescription example is an interesting one. Okay, great. You can refill a prescription for $4 instead of $150.
Sure.
Let's see if that works, and let's see the upsides and downsides of it. We're going to learn a lot from that state pilot.
Sure.
But that's just one example. We want 50 different examples to play out, and that's the thing that I worry about.
Yeah, I mean,
if we wait just for national, basically.
Yeah, I mean, there's an argument to be made also that I thought actually that I think Jonathan Slotkin wrote a great op-ed about Waymos seem to have proven that they're so good that actually it would be unethical to not roll it out everywhere.
So good,
right? And I think if we can do something around in the lines of hey, this pilot or this thing looks so good, we really just gotta boost it everywhere.
Yeah.
I think that can actually be maybe a different way the federal government thinks about things, rather than be hey, we're gonna set blanket rules.
Yeah.
It can be all these places should test their own things out. If something looks like it's working, then we make that the rule for everyone else. And then speed run getting those features or programs out to everybody.
Yes.
Rather than be hey, we need to create a yes, it's working, no, it's working rule set for every state.
Yeah.
Just be go run your own pilots and tests, and then let's get it up.
The New York Times article around Waymo is a perfect example, and actually, ironically, it pointed to healthcare and life sciences as a industry that already has this framework, which is if you're running a clinical trial
and it looks great,
and the evidence is as clear as day,
you stop the trial.
At some point, it becomes unethical to continue the trial, because you're giving the placebo to the control arm, and it's causing harm.
It's harming,
and it's harming them, and so. What is the framework like that here? I think this is going to be one to watch.
Yeah.
That relates to IP.
Sure.
And all the IP debates around healthcare AI.
Yeah.
So you said intellectual property lines will be drawn in healthcare AI with lucrative copyright and licensing deals.
Yeah.
This photo, which we'll put it up for the people out there.
Sometimes my wife walks in on me doing my work, and in this case, she's seeing me output an image of Elmo choking me out, and she's like, "Is this really what's putting food on the table?"
Yeah, exactly. She's wondering if you have a real job.
Yeah.
So I mean, but it's crazy. So lay that out. Lay out that case for AI overall.
Sure.
All the drama deals and litigations that happened last year, and then what does it look like in healthcare specifically?
Yeah, I mean, in the foundation model side, the big issue has always been like, what does copyright look like in an era where the AI is sort of just regurgitating or spitting out things, or like using IP in ways it was never supposed to be used.
Yeah.
Like Elmo choking me out, right?
Yeah.
And now there's a bunch of lawsuits / partnerships that have been happening where different foundation models now are allowed to use the IP from different companies. So I think Disney invested in OpenAI, right? And now presumably can use their IP within it. So, you clearly see these lines being drawn, and Anthropic had a huge case against people who have written a bunch of books and all this kind of stuff. So that's being figured out, right? Healthcare has so many copyrighted things. Disease scales, for example, like CPT codes. Like so many of these copyrighted things, probably has the most behind a paywall expensive PDFs that exist of any industry somehow. But
are we the market leader in paywalls?
We must.
That's really sad.
We must be. Come on.
Fair.
So if you want to use any of those things, you got to pay a fee. You got to pay the piper, right? As long as we are in a system where you have to use those standards or whatever, it behooves a lot of the healthcare AI applications to create licensing partnerships with these people who own the IP, right? So that'll probably happen realistically. I think maybe a more interesting one, and I sort of posted this online the other day and kind of got roasted, but I think it's an interesting thought experiment, is like, I think protocols are IP, right? Like, I think that the Peter Attia longevity protocol
I would buy
IP. And I think one question has always been like, okay, if you are a Peter Attia, right? By the way, I don't know Peter Attia, but hey, man, if you're listening, like, let me know what you think.
I would buy.
Let me not die.
I would buy the Peter Attia protocol.
Yeah,
because I can't. His to be on his client list, he charges a really high fee. But make that available.
Yeah, like also like if there's a Peter Attia trained agent that is implementing the protocols at the patient intake level, at the like dose escalation level, whatever, then you can potentially just see a regular doctor that has a wraparound of the Peter Attia protocols that, helps you do all the things that you normally would at his clinic, essentially, right? And you pay maybe a lower price than the normal clinic, right? But I think that becomes an interesting thing of like, hey, I want to create my own protocols that I think are maybe slightly outside evidence-based medicine guidelines, and then gets implemented at other clinics, right? But a lot of those clinics might implement it in the form of AI agents or other ways to actually execute that. So that's like a slightly different area that I actually think is maybe more interesting. But at the baseline, you're already seeing like open evidence partnering with like JAMA, or I think it's New England Journal of Medicine, just to be able to like pipe that data in. So all the paywalls will probably end up finding their own specific healthcare application and like be like, hey, this is the one we're licensing it to. Whether it's exclusive or not is sort of TBD. But at least they could probably have those agreements.
What do you think are the biggest data sets in healthcare that are still untapped? Because there's builders listening that are just trying to figure out what's next. So AMA CPT codes, Milliman clinical groupers, health system clinical EHR data, PBM data, famous doctors with their own protocols. Like,
but the honest answer is I think a lot of those data sets are like not great data sets.
Yeah.
They were created and built and used for a very different purpose than probably want to use it today, right? Like today we use so many of those data sets as proxies to figure out something other ground truth, right? Like for example, we will use prescription claims data sets to figure out if a person has diabetes, rather than just seeing like, hey, let's connect your CGM and just see like, do they have diabetes or not, right? Like I think a lot of the existing data sets in healthcare are like quite bad, actually. And I actually think the more untapped data sets are these net new data sets that are going to be created either from screening, wearables, etc., but also things like scribes, for example, right? Scribes capture raw audio text data from the encounter. That is like totally net new data set that is really interesting to use, that you can do with, lots of things. Like, for example, for anyone listening, one thing that I think would be really interesting is net new medical malpractice carriers. Like, why is there not now a Metro Mile equivalent, but for MedMal, right? Like, you put a thing in, if you are, we sort of listen to how you practice medicine. If you tend to do it within like appropriate guidelines and all this kind of stuff, we will actually give you a better rate, right? Like, I think a lot of these net new data sets will actually allow us to do other interesting downstream things too. But I think the old data sets are just like, they're just kind of jank and used for things that are like, they're not supposed to be used for. We got to stop using fucking claims data sets for real world evidence. Like, it's just that it wasn't meant for that,
Yeah. I mean, especially like PHRs are back. And then OpenAI bought a PHR.
Yeah.
And then maybe PHRs are not back anymore. And then maybe the LLMs are going to do it. But like personal health, people are uploading a lot more. I'm uploading a lot more of my stuff.
This is a great example, right? Like PHRs now, obviously for personal health records, have been one of those ideas that everyone has pitched every year. And then, but at some point it'll happen, right?
Course.
Like it's just kind of unclear when. And the missing piece has always been interpretability. Right? It's like, hey, you're giving me all this data, but I don't really know what to do with it. I got to go back to the doctor anyway to interpret it.
Right.
Not that useful, right? Now with AI tools, you have more interpretability that unlocks a whole use case. And more importantly is that it gives patients a reason to now dump more data into these things, right? Before it was like, okay, like if I dump more data into the personal health record, my doctor doesn't want to see all that. It's a lot of noise. I don't know what to do with that. There's nothing more to do, right? Yeah. But if now suddenly I'm like, oh, I'm actually getting more interesting answers the more data I put into it, then suddenly you have patients wanting to generate more of their own data to put into this, right? Like that creates totally net new data sets. Patients might actually also like, you came from the clinical trial world, for example, like, one part of clinical trials is patient-reported outcomes.
Totally.
Those like diaries that patients have to fill. No one's filling that out,
no.
Right? It's a terrible completion rate. But suddenly, if you're like, hey, you'll actually learn more by chatting with this thing that we have that will tell you more answers, maybe about the drug or anything like that, there's now an incentive to actually like chat with this and give it more information. And that's like totally net new data, which I think is also probably closer to ground truth of how people are actually feeling about their health and all that kind of stuff.
That extends to anti-AI populism.
Yeah.
So lay that one out. We effectively just spoke about the bull case for AI bridging the supply gap. We don't have enough docs, not enough physicians. AI is going to bridge the gap. Explain the populist revolt.
I think it's a few things, right? Like one, I think, look, the reality is healthcare is a jobs program in the U.S.
Yeah.
Right?
23 million.
It is the number one employer in the U.S., especially for, I would say, these like, kind of administrative jobs in particular. Like the number one job category is still patient care, right? Like it's patient-facing caregivers and all this kind of, LCSWs, all this kind of stuff. But there's a big layer of administrative people who are very comfortable in their jobs, their jobs can definitely be automated, and do not want to see that happen. So I do think one thing you'll see is just people afraid of job loss, as with any other new technology as it comes out, and want to fight back against that. The second thing that I think you'll see happen is there's going to be a weird fight that happens between what a doctor thinks they should be doing and when they think that the AI should be telling them what to do, right? Because this is going to be like a strange thing where either hospital admin or payers or something are going to start saying like, hey, you got to like consult the AI for this XYZ, or we're mandating scribes and the scribe is not that good, and then suddenly they're like having to repeat a lot of stuff. Like I do think the implementation of this kind of stuff is going to be kind of clunky, and because of that, people are going to have bad experiences with it, and when they have bad experiences, they're going to feel a little bit like they're being encroached on, right? So I think those are some of the areas that'll happen. And then I also think realistically there's going to be some big AI mistake that happens in some capacity. You're kind of already seeing that with like ChatGPT, with like, the kids who are committing suicide because the bot is like convincing them to do stuff. And people are already having some like, hey, we need guardrails here, right? There's some backlash on like what we think how it should be allowed to interact with kids and all that. And I think you'll see like a big healthcare issue that happens where someone's really misdiagnosed really publicly, or something like that happens, and then people are going to say like, hey, we need more guardrails here, or we need more observability, or we need something, that tells us that like, hey, this is a one-off, or we won't let it do really high risk things or something, I think people will push to regulate those things. Whether it's right or wrong, I don't know, but I just think that'll happen. And by the way, already saw this with like the internet when it happened, right? Ryan Height laws are a great example of this, right? Where I believe it was a teenager, got access to controlled substances through a internet-enabled service of some kind, and then they put rules, and I overdosed, I believe, and they put rules around like what you could do and what you couldn't, and then those rules just stayed for a really, really long time. It's hard to roll back rules like that once they get implemented, and if the case is high profile enough. Yeah. So the question is, this will definitely happen. What is our response going to be as a country?
Okay, so let's just go through the three major populist arguments. Sure. So and you touched on them. So the first is AI will destroy all the healthcare jobs.
Yeah.
Okay. The second one is AI makes mistakes and patients will die.
Yeah.
And then the third is that AI takes away patient choice and autonomy and creates confusion for the physician, right? Because it's that, can the patient choose, or is the doctor required to get the second opinion anytime? So let's just go through each in turn. The AI describes, or the AI will destroy the healthcare jobs.
Yeah.
Go against that one.
I mean, as in, like, do you want me to say, like, why we shouldn't?
Yeah, like, argue against the populist case.
I mean, the argument is, that one is easy, right? Which is, like, everyone always complains about the administrative cost and bloat of healthcare. So we should definitely want to decrease that. And not even just from a cost perspective, but from, like, an experience perspective for everyone. No one likes dealing with the administrative part of healthcare. Yeah. So it seems very obvious that we should try and remove that. And actually, like, maybe that will push more of those people into jobs and roles in the healthcare system that don't exist, but actually would be really useful, like proactively taking care of people or checking in on them or doing more like the community-related stuff for patients in the communities of the providers themselves. So those are like bad tasks and jobs, and I think are just like we shouldn't have them. So I think that one is like the easiest to be like, listen, no one's arguing for admin, man.
that one's easier. And by the way, that's always been the anti-technology argument.
Sure.
It's automobiles were taking jobs from horse trainers.
Sure.
ATMs were taking jobs from bank tellers.
Yeah.
And in a lot of those cases, not all, but in a lot of those cases, we have more of that prior job, but just doing something else. We have more bank tellers today, as an example, right? So I think that's one big one. The other one is just that it's super supply constrained. So I think in some other markets, there probably will be some more drastic job dislocation. But I think in healthcare, it's just a simple supply-demand mismatch, right? There's just, we're employing more than any other sector, and yet we still have record shortages.
Yeah.
And it's not getting any better, right?
Yeah.
So
there's an unlimited demand for healthcare services.
Unlimited demand.
So if you enable people to get more services, they're going to get it. And that's also probably not a bad thing, right?
Yeah.
People want to engage with their health. Like, we should actually probably let them if they really want to.
Okay, go through the second. So AI makes mistakes and patients will die.
So I think the case here is more around, we have to think about type 1 and type 2 errors a little bit, right? Where it's like, okay, it's obvious that AI is going to make a mistake at some point and something bad is going to happen. But how many net people did it help, right? And you have to weigh the costs between those things. Like, for every, and you even see this just like anecdotally on the internet, for every person that it's probably going to make a mistake for, it's also has one person that was like, I was never diagnosed and I found out I had this rare disease thanks to dumping all my files into Gemini, and now I learned that like I can be saved. Some random case like that. But also just like the median level of care, if it gets better, then it's a little bit of just risk reward. For every mistake that happens, how much benefit is going to happen? And I think the answer probably is it's in the median AI implementation at some point is going to like raise the bar for everybody, even if it means a few edge case mistakes. And I think you have to be comfortable with that if you want to roll this out at scale.
And humans make mistakes too.
Humans make mistakes too. Yeah. Like again, the Doctronic one I think is just like an interesting case study here, where it's like what you would want to do is compare maybe like the Doctronic autonomous AI to like you're filling out a form for like an asynchronous erectile dysfunction company. Like they probably make mistakes too on the other end, right? Like, but if it's the same level of mistakes, then we should maybe be okay with it if the cost is cheaper, but also maybe it's actually better, right? So even if it makes some catastrophic errors every so often.
There's so many counter arguments here, but the one that interesting, which you already alluded to, is that AI creates an audit trail because everything is documented. Yeah, and so people are really concerned about the black box of AI, but you can see the decisions at least now in this way as a sort of loop. And so that also creates an interesting data, like you have data provenance. You can look back and you'd see why a decision was made.
Like where in the reasoning did it mess up?
Right.
Actually fix that.
Right.
And not have that happen going forward.
Right.
Imagine trying to deploy that fix at scale with all the human doctors.
Can't do it.
Right. It's really hard. That's actually why we have evidence-based guidelines. Right. Like you're trying to prevent a lot of those cases. And in order to do that, you have to deploy care guidelines. But if you could make a change to an AI model at scale, actually, maybe that's easier.
The third is around AI takes away patient choice. So if your insurance company uses AI for prior authorizations, you're not opting into that.
Yeah.
It can be dehumanizing. Now I'm talking to an AI chatbot, but I really want to talk to a human. It's related to the physician piece where now you're second guessing a doc every single time.
Yeah.
What do you make of this?
This one is a little harder, but again, I do think this process is already happening. It's just with a human in it, right? Yeah. And because of that, it can be there's a lot of variability in who you talk to on the other side of things, right? You'll see lots of patients, for example, that know like which person you want to hit for customer service to like get the right answer and blah, blah, blah.
Yeah.
And there's a lot of variability in that. So maybe this provides more standardization, at least, like you understand the rules of the game and you have to, basically that's how you play it. And it's more understandable and you get answers faster at the very least, even if it's not the answer you want, at least it's quick. But also at the same time, again, it's just like you always have to compare it against the human being, I think. And the core problem, I think, there, especially with like payers, prior auth, all that kind of stuff, has nothing to do with technology, right? It's really just there's an incentive misalignment between the payer provider and insurance company in a lot of cases. The AI is probably just like encoding that, but it's not that different than deploying a call center agent with rules who needs to like follow them, right? So again, it's the same as the other ones where it's like compared to the human version of that, is that better or worse? If you can get answers faster, I would argue it's better, right? No one wants to be like waiting to hear from the insurance company if the prior auth went through. At least get the decision quickly so you can move on to the next thing at least and argue or whatever it is, but just get the decision quickly.
Yeah, I've heard this argument feels like the luxury argument to me, where sure, if we could have one doctor for every patient and they would get 24/7 attention, then sure, maybe AI takes away from that, but that's not the reality. The reality is we've got a labor shortage and we've got long wait times. And so if you've got a AI agent that's 24/7 available, infinitely patient, has all your medical context and getting back to you quickly, I think people want that.
Definitely.
And I think I think in areas where we can create choice, I think the data, my expectation would be the data would suggest that people want that.
But the bot's got to get better, man. Have you like called an AI bot recently? Like, I mean, some of them are real bad. And I'm like pressing 0 to talk to a human. Yeah. So the deployment, I think, actually really matters here. And my worry a little bit is that payers have no incentive to actually make this like a good experience.
Yeah, that's like a version of the Turing test. Is at what point do you not automatically just say representative?
Yeah. And they're like, I am a representative. Excuse me, I'd like to not talk to a bot. It's like, sir.
How do you know? How do you know I'm not a representative?
It's like, oh, I'm sorry I offended you.
Yeah, exactly. Okay, so we've talked about AI, and so we think dollars are going to go in different places.
Sure.
They're going to spend it on screening. They're going to spend it on AI applications. Yeah. Now let's talk about drugs. So you had a prediction in there, GLP-1 usage rates will more than double.
Totally.
But they won't work well on mental and behavioral health issues. So set this one up.
Yeah. So the big thing this year is that the pill version of Wegovy is coming out.
Yeah.
Right. So, suddenly, and now also there's a ton of negotiations that have happened both from the government side to bring these costs down, as well as pharma going direct to consumer, which is a very new thing, and also the PBM rebates, right? Like everything, this is such a competitive drug class that the prices are going down, right? And new modalities now are being created, like the pill form, and you have these like new stronger doses or different combos, like tirzepatide and retatrutide and all this kind of stuff. Incredibly competitive drug class, right? So, and it is also, again, like basically near infinite demand. Like people, everyone wants to not be like obese, right? Near infinite demand here. So it's clear that a lot of people are going to be taking this drug, right? It's just clearly going to happen. I think maybe last year we were like 10 to 12%, if I remember correctly, or so, maybe 15, somewhere like that.
That sounds right. Yeah.
So now with this pill coming out and the prices coming down and everything, like it's gonna go up for sure. I mean, the percentage of the U.S. population that is obese is like gigantic. So the number of people who want to take this is gonna go up. I don't think anyone's gonna doubt that a lot of people are gonna be on this drug, right? Like it's gonna be high. My guess was 30% just based on where we were at a baseline, and it's always nice to put numbers around predictions. So let's see if I'm right about that. The mental behavioral health one is interesting because this is, it's funny. It's like in this whole vein of people doing self-experimentation, one thing they have been doing is around like, let's try GLP-1s for everything, right? And a very classic area is like, oh, it's like helped my mental acuity when I like microdose Wegovy in the bathroom, right? Like, so people have been experimenting on this, and they're like, oh, it brings me so much mental clarity, and lots of theories around how the actual thing that these drugs are solving is really a dopamine regulation issue on how you think about food. So really regulating food addiction, essentially, right? And can that cross over to other addiction types, right? But a lot of trials in the past have actually, in a similar-ish mechanism of action, have tested some of these areas, like in smoking and alcohol and all this kind of stuff, with like not fantastic results actually. So maybe changing the dosages and the formulation and all that kind of stuff does change that, but it doesn't seem, again, this is just a guess, and I'm not a doctor, I'm just like a dude with a newsletter. It doesn't seem like it's going to work that well for addiction, and even like they tested in Alzheimer's, it didn't really work out that well. So I think there's still a lot of room here to like experiment, but my guess is just for mental and behavioral health, it's like not going to work that well. One thing I did actually hear recently, I have quite a few friends / people who just slide in my Instagram DMs for unclear reasons about their patient journeys. And whenever I post about GLP-1s, people will tell me like a different GLP-1 story that they have. And a lot of people with like inflammation related diseases, so think like Crohn's and ulcerative colitis or psoriasis, for example, have found that microdosing the GLP-1 actually seems to be helping them a lot. Like one person just recently told me they stopped their biologic and the GLP-1 seems to work for them. And that actually might be a different interesting area that it might work better than we expect. But I don't know, mental behavioral health stuff, I don't think it maybe is going to work as well, but I could be totally wrong about that.
We're going to learn a lot. It's clear.
There's some trials also, I think, readouts this year.
It's clear that there's a lot of trials running on a lot of different things. The meme of the GLP-1 golden hammer. Why does it work on everything I touch? I mean, the efficacy is dazzling. It's crazy how many places it's working.
Put it in the water supply, man.
I mean, it might be like the next statin or the next just like put in the water supply kind of thing. So I know less on that part, but I would very much agree that there's basically 5 accelerators that are just gonna, it maybe goes past 30%. I mean, we'll see. I mean, the consumer awareness, like I think the dazzling efficacy for a lot of conditions has captured the intention of a lot of people. It's in the zeitgeist. It's out there. One you didn't talk about, but I think is important, is just the rate, and this is true for GLP-1s, it's true for all new medications, therapeutics, devices, I think, which is just evidence dissemination is also happening faster. Certainly tools like Open Evidence and ChatGPT, docs using that means the information gets out to the community, treatment patterns change more rapidly, and I think there's some data to support that.
Yeah.
But also to consumers, right? Because we're playing around with these tools and they're telling us things. The convenience factor, no question. I think the oral formulation is a big deal. The new channel, relatedly, the new channels I think is something that I expect we'll see a lot more of, which is, you had the oral formulation of Wegovy on day one of launch, effectively, go live on all these digital health channels. So it was on Ro, it was on GoodRx.
Yeah.
That one's kind of a newer phenomenon.
Yeah.
It used to be that you'd go your mainstream channels that your commercial pharma org
Totally
has you, you know your people, your docs. You're going to talk to the docs that are the influencers, the KOLs.
Yeah.
You're going to go talk to the docs where you ran the study and
now
there
you're
were trial
talking to
sites.
TikTok influencers.
Now
They're
you're
the KOLs.
Now you're talking straight to TikTok, right?
Exactly.
Like it's crazy.
Yeah.
So I think that is another channel that is only getting bigger. And then I think the fifth is just around reimbursement and payment. I think to your point that some of these categories are complex. I think the formulations are changing, or our patients are getting more formulation options, and those may have different prices or different. They may distribute through different channels, and that'll have its own. There'll be their own competition. Then obviously, Trump RX is going to bring prices down, and you're gonna just have a lot more channels and a lot more options. So I'm excited about that.
Drugs are a consumer product. They always have been.
Yeah.
Obesity is just the area which has so much demand, and people understand their own disease pathology so well that they know how to buy, like, what they want. Right. Versus it's hard for me to be like, hey, I know what cancer drug I need, or like rheumatoid arthritis or whatever. Right. But it's like, hey, here's a pill that actually like helps with obesity. I understand that I have obesity, and it's the first. I think it's very cool to see a drug company treat itself like a consumer products company. It's very rare.
Yeah, and I think some of these channels where I think if you've got now, effectively an AI doctor in your pocket, whether it's physician supervised or not, gives you another channel to have conversations and understand what's right for you and what's not. I think a lot more patients are going directly there to their doc and saying, hey, should I be on a GLP-1, right? So there's just a very different level of pull versus like the old school pharma ad that's like, ask your doctor about X, and then let me tell you the 15 side effects.
Yeah. And they're like having a grand old time in the field. And
everyone's
like,
smiling.
You might shit yourself to death.
Yeah, exactly. Okay, so that's one drug class that's growing very quickly. There's another category of drugs.
Of course.
Other peptides, so not GLP-1s.
Yeah.
You have a prediction: the FDA will crack down on gray market peptides and create regulations for legit compounding facilities.
Yeah. I'm in SF, and I've been trying to find these peptide parties, and no one's invited me. I'm a little offended.
Okay, so we'll show a picture of these peptide parties from that one article. I mean, it's crazy what's happening with right now. So let's set this one up. But you're predicting the FDA cracks down on gray market peptides in 2026. The plot twist is basically, so your prediction, I think, came out at the end of December. 6 or 7 days later, RFK Jr. says FDA's war on public health is about to end, including its aggressive suppression of peptides. Okay, so for people that don't know, so peptides are amino acid chains. There are some FDA-approved peptides. GLP-1s are an example, but then there's a whole category of unapproved peptides, many of which are coming from China or at compounding pharmacies. Both are unregulated or gray area areas, and people are trying them. And there's peptide parties, as we've discussed. They look like raves, but everyone's drinking non-alcoholic beer and soda water, but then injecting themselves with needles. And so
they're worried about what the alcohol will do.
Right, exactly. So on one hand, maybe we're becoming healthier, and then maybe we're trying new things.
Seriously.
So sorry to interrupt you, but lay that out.
So I mean, it's actually interesting because you would think it's maybe just like the small biohacker types, but like I know quite a few people who are older who take it for things like pain. Like BPC, I think 157 is a very common one that people will use and inject in their joints to help alleviate pain. And I actually think one of the things that shows is for their areas where there's like unmet need, right? There's not really a lot you can do for joint pain or whatever. That people are, because pain is so bad, they are willing to try a lot of things, right? Including these like really experimental drugs. So, I mean, the prediction is not that we're not going to have more peptides in the U.S. It is that the current way in which we procure peptides, if you want to do them, is through very shady sources. Like, to the date, people are either buying it online in these sites that look like, you know, infomercials from the 90s, or they're going to their doctor and they're like, hey, where can I get this? And the doctor has some relationship with trusted compounding pharmacies that they, you know, have seen or whatever. And it's just like all over the place, right? There's not really any regulations around how we procure, source, you know, measure the, for example, like the dosages and all this kind of stuff. It's just like total Wild West. So my theory is that there's, you know, what I thought was going to happen is there's going to be some, again, big news story or whatever of like a bad batch that like really harmed a lot of people. Then suddenly they're like, we got to do something about this. And then the U.S. would basically create pathways to create more accredited versions of compounding pharmacies, effectively. So that's like my guess on what happens. I don't think, and again, this kind of brings it back a little bit to the GLP-1 conversation, which is there's another part of this, which is like the question of how do we think about IP laws around drugs in general, right? Where it's like if I come up with a new drug and I'm like, hey, here is this new drug that cures joint pain, and someone is like, I'm going to make a compounded version of that and charge 1/10 the price. What is even the point of having IP laws in the first place, right? So I think that brings up a very separate and interesting conversation. But this administration, I think, is more on the side of we should just make things cheaper for everybody, and, you know, pharma basically like is like maybe losing that battle. It's not super clear to me. And the other thing with peptides is like there's a whole range of them, right? Like there's peptides like retatrutide, which is actually still being studied in clinical trials today. This is just sort of like a shortcut way to get them faster versus like totally unstudied ones that like do God knows what, right? So, you know, if you go to these like bodybuilding subreddits and all that, they're always on the fringe of this stuff. Of course, it's a little bit of survivor bias. The guy who, you know, injected some random peptide is not posting on those forums anymore. Totally. But yeah, they're trying all this stuff, and, you know, question is, should we actually be capturing structured data from these people if they're doing it anyway?
Totally. Well, so first of all, it ends up on a subreddit, and then it ends up in an LLM.
Yeah.
And then you have an LLM that's saying, so you got kind of dangerous loops there.
Exactly.
You know, this is a complex one, because if you ban imports of these peptides, then you probably result in even more underground movement here. And then if you approve certain compounders as compound pharmacies as you're allowed to do this, then are you informally suggesting that you're okay with this and then encouraging it? And so it's complex.
I mean, I think they are sort of doing that, right? Yeah. Like it all falls under this, like, I think, general ideology around patients should be able to choose, and patients should be able to absorb risk themselves in exchange for lower prices if they so choose to do so. Yeah. Now, again, totally depends where you fall on the spectrum of, like, do you think patients should be able to do that or not? Can they make good decisions here?
This is the freedom versus public health argument, and, you know, it's as old as time. I think the thing you alluded to this, which is it would be a real tragedy if people are going to do it anyways, no matter what happens, and then we don't learn anything from it. Yeah. So if people are going to do it, can we create kind of like what we've done with AI, where we're creating, you know, in certain states are creating sandboxes where we can learn from it. Yeah. Can we create that here too? Yeah. But the problem is the moment you open up the door a little bit, you're endorsing it.
I know, exactly. If you're like, hey, listen, I mean, this is basically like the safe injection site version of peptides, right? So as soon as you say, like, hey, listen, send us your data, you're basically saying, go do it.
Yeah.
And I don't know, should we want that? Are we going to be taking peptides in like 10 years?
Really hard.
Can I tell you an interesting?
Please.
So in the U.S., we run 3 phases of clinical trials, right? Phase 1 to test for safety in healthy volunteers. Phase 2 to test for efficacy to see if the drug actually works in small populations with the disease. Phase 3 to see if that replicates across larger populations in many geographies, blah, blah, blah.
Right.
There is a movement out there that is basically, and it's coming to the US now, actually, that is basically like, why do we have to test for efficacy at all? Why don't we just test for safety and then let the market decide what efficacy is, right? So as soon as a drug is proven safe, then we should just be able to, I should be able to go get it if I want to, right? And you'll bring drugs to market way faster that way. And then the insurers will basically look at the efficacy data to see how much they'll pay and reimburse it. And then over time, you'll have more real world evidence to say like, hey, this is working, this is not, but people can make their own choice.
Yeah.
I'm not saying it's right or wrong, but like Montana, I believe, passed a law that allows you to do this, I think, for gene and cell therapies, where you can, I think, go and try cell and gene therapy, basically if it's proven as just like doing phase 1. And they've been doing this in the Honduras, in these like charter cities, for like, gene therapies for follistatin and all this.
This is the Brian Johnson
Netflix
exactly.
Yes. So peptides are sort of an extension of that ideology a little bit, where you're like, maybe I should just be able to try this myself and see.
The libertarian sort of free market, person in me likes that. But I think the challenge is then, okay, what are you allowed to market? So if you've only tested and demonstrated safety, then what are you allowed to say to convince and persuade people to try this thing? And can you make medical claims around efficacy if you haven't tested it?
Yeah, that's a good question.
And then it's a slippery slope. And then you let one person make a claim, and then all of a sudden, the ones that truly are very efficacious become very difficult to decipher from all the ones that are just saying things.
Yeah, I don't know. I don't know the answer to that. And again, this is like maybe where patient biobanks become interesting, where you're like, can I interrogate a registry of outcomes and see what it did anyway? But not totally sure what they're going to do about that.
It feels more like food too, where I'm not an expert in food testing, but you really just have to make sure it's safe and it's
supplements.
Somewhat edible. But then you let the market decide if it's efficacious. Is that good? I mean,
no one likes the U.S. food system.
Is the U.S. food system good? I don't know. So we're working on fixing that.
Food has that concept of generally regarded as safe, right? Then if as long as that, you can rip it. Actually, maybe we should have swapped the two.
Oh gosh.
And actually, food should have gone through more testing before it comes to the system, because it's at scale for everybody. And then maybe drugs should have been generally regarded as safe. Maybe that's the way we should have gone.
Okay, so we covered some of your more spicy predictions. There's more in there that I thought were interesting. We don't have time for them. Check them out if you're watching. We'll link in the comments here. But one, you were sort of predicting out of pocket. So tell what's going to happen out of pocket, and make a little prediction there.
We're like all in on events now, and in person and IRL, and I think maybe this is like a broader content thing that's happening, but just like. I'm just like not having fun on the internet anymore. I feel like AI has like really just like distorted how content is created, and then the algorithms are sort of boosting stuff that like doesn't bring me enjoyment anymore.
The AI slop is killing you.
AI slop is killing me, and like when posts are like becoming a part of the zeitgeist, like it's just like now I'm getting mobbed rather than like having fun. Like the discussions are not as interesting to me. And I'm not learning nearly as much online. And so we are all in on events now. And so we're doing hackathons. We have this like micro conference format that's like all workshop oriented, really role specific. And also like, we're actually doing a lot of like workshops teaching people like interesting ways they can use AI in their work. So we're like doing a lot more in-person stuff. And then also, like, for me personally, it's kind of interesting running, like, a creator-focused business or something, because it's hard to scale, right? It is, like, an interesting question of, like, how do you scale a single person? We have been exploring a lot of AI tools ourselves internally. I've been Claude Code just, like, grinding, and how do we use that in different parts of the business, like, scale up ourselves, basically. But, yeah, really, it's, like, a big focus on events this year, and just doing more fun healthcare stuff, keeping healthcare fun, you know?
Keeping healthcare fun. 2026. I mean, even since you wrote the article, we were at JP Morgan this week.
Yeah.
The news is nuts.
Yeah.
Things are happening at crazy pace. So at least probably in our careers, I'm sure you'd agree, this is the craziest time in healthcare,
sure.
period.
I will say it is the first time. I mean, I've only been doing healthcare stuff for like a decade, so like take that with a grain of salt. But it's the first time it sort of seems like I see a path to either deflationary or flat spend in healthcare. Combo of AI, GLP-1s, an administration that's kind of trying to focus on bringing costs more in line, like that's just like an ideology, in the form of like consumer spend and all this kind of stuff. Like I do see an interesting path now to maybe getting spend more in control. TBD. I mean, the timelines on that horizon are like very unclear, but there's just so much cool stuff happening.
I'm equally as optimistic, but I see it differently on what happens.
Okay.
Which is that I think healthcare is going to get a lot. It's going to get a lot better, but we're going to spend even more on health.
Okay.
And it actually has nothing to do with what's happening in healthcare.
Okay.
And it's more just a function of what's happening to the country, which is as people thought that healthcare was going to bankrupt us for a long time, but we keep spending more and more on healthcare because our GDP keeps going up, and we have more. Other things are getting a lot cheaper. Electronics, basically a lot of the industries that software has eaten have gotten a lot cheaper, and it allows a country to spend more of its money on other things that it values, healthcare, education, et cetera. And by the way, real estate, and a lot of those sectors have become a lot more expensive. 5-10 years from now, are we going to be spending more on healthcare? I think we're going to be spending way more, but we're just going to get a lot more for it because these things are going to get better. We'll see. I think either way, it's a really fun time to be building it.
Let me do a little further out prediction.
Yeah.
Sort of related to this, which is as the U.S. moved from a manufacturing-based economy where that went overseas, we became a services economy.
Yep.
A big part of that trade was that healthcare basically became a jobs program to effectively replace manufacturing, right? Now, if we really want to see the productivity gains from AI, we have to figure out what the next thing is post-services economy, right? And that's not just healthcare, that's for a lot of stuff, right? Like, a lot of the jobs that are white-collar jobs we're already seeing as like sort of AI-able, right? So we need to figure out something that's like a little bit post-services. One theory I have is that we are going to move to something that looks, I don't know exactly what the term is, but maybe it's like a community economy kind of thing.
Creativity economy.
Creativity, or just like, help your fellow person economy. And healthcare actually provides the existing rails to already do that.
Yeah.
And one form of that, for example, is like paid caregivers, right? Yeah. Or what effectively almost looks like paid friends, essentially, right? Yeah. Like you see this in like Medicare Advantage. Well, they'll pay people to come just take care of some of the older folks, etc. Yeah. So actually, that might be the way that healthcare spend sort of absorbs a lot of this job loss, is just by basically saying like, hey, we think that the way that the next economy going forward is like people just feeling good about their lives, and not necessarily just from like a pure healthcare perspective, but healthcare provides the rails to do that essentially. Yeah. And that's why like a lot of states have these like paid caregiving programs, for example, that are some of the fastest growing jobs in those states.
Yeah.
So, that might be one version of like how healthcare spend increases.
Yeah, I think the jobs thing and then what we spend are sort of two separate but very related things. Like maybe we have fewer healthcare jobs in the way we define it today as a percentage of overall of the overall population and where people are working. But if it's something that we value more and there's new exciting stuff and we can afford it, prices will rise. But we'll see.
Yeah. I don't know. We'll still be in this industry when that happens. That's for sure.
No doubt, and we'll be
still faxing.
Yeah, exactly. We'll fax. We should have just done this podcast by fax. Honestly,
I know.
That would have been more fitting. A lot of people, what I've seen, which I've been really excited about too, is technology broadly and people who are working in technology, there's an increasing percentage, this is anecdotal,
Sure.
increasing percentage of people in technology that are coming into healthcare.
Sure.
They're interested, I think the stuff that you're doing to educate people about the complexity of healthcare, it's not actually that complicated. Come learn it, come check it out.
Yeah.
A lot more people are entering. And I think that's awesome. I think that's why, that's why I wanted to feature this predictions piece as an example of just, there's cool stuff happening in healthcare. Come learn about it. Come make come make an impact. But in the age of AI slop, it's hard to figure out what to read and what to work on. So what is your content diet?
Ooh, one thing that I've been doing recently is I'm going way back to primary source stuff now. Partially because the AI tools also now make it easier to parse through like really long documents and just really focus on the parts that I wanted to focus on. But like my most like old head behavior now is like I print out like a lawsuit and read it in the morning, or I get print articles or long form pieces or white papers and stuff. Like I'll print out and actually read it. I think there is like actively more wrong information on the internet now than right information. Like I think that actually has tipped. And so now it's time to like go back to just reading the primary. And also I just am having more conversations with people directly where I'm just like, what are you experiencing? Like what's interesting about what you're doing? And I think, just talking to people about the stuff they're working on and then following up on some of the things that they talk about is just way more fruitful and interesting now at this point versus like trying to read online and believe that that is truth. Like I've now crossed that Rubicon. Like, so I read a lot of white papers and stuff like that. And then there are a lot of Substack people and a lot of people who I think are doing a good job of writing like, what I think is more sort of reliable information and learn a lot from them.
Yeah. I found LLMs have been a great translator of complex scientific white papers that if I'm not an expert in that domain would just take me forever to parse through. And I just drop that into ChatGPT or Claude or Grok or whatever and let it translate for me. And then I can always talk to people about it and go and follow up. But the pace of stuff that is emerging right now, you can't keep up. You need an interpretation layer to our earlier conversation. So that's been
exactly. Especially like if you know a lot of the basics and you really just want to go to the more advanced stuff, like just remove all the basic stuff and just show me the stuff that's like particularly interesting. And so it's been fun.
It's awesome. Well, my man, I appreciate you coming on.
For people who don't know, by the way, I was like, yo, Jay, let's catch up. And Jay was like, yeah, man, let's do a podcast. And so that's like very peak male relationship.
This is the modern male relationship is if it's not recorded, why are we even doing it?
Next time we'll have a peptide on the table and we could just take it together.
And we just show that on video too.
Exactly. Yeah, man, thanks for having me.
Cool.
Appreciate it.
Thanks for coming.